not just talking about one thing. Okay, so in terms of inattention, the quick way to think about people presenting with inattentive type of ADHD is I would call them like my space cadets when I'm talking about kids. Forgetful, daydream a lot, have trouble focusing for long periods of time. You're constantly trying to call them back to attention. It's as if you told them something and they never heard it. Okay, so that's the inattentive subtype. Presentation. Hyperactive, impulsive, these are our energizer bunnies. They're always on the go. They're talking as a whole bunch. They're moving a whole bunch. They're jumping, they're running, they're climbing when they should be sitting. For an adult, you'll see that they can't stop talking or they bounce from one subject to another. Okay, that's that hyperactive, impulsive presentation. A combined presentation is when you've got both, 6 out of 9 of the inattention, 6 out of 9 of the hyperactivity. And the thing you've got to remember is that this has to be consistent across multiple settings. It can't just be at school, this kid is fidgety and hyperactive, and at home, you're having no problems, right? We think in terms of our diagnostic assessment and research that we need to see this in a social, occupational setting, so home, school, and in the clinician's office. Okay? Sorry. All right. So, in terms of like getting a high quality assessment, it's really difficult because we don't have like a blood test that we can do where we can draw blood and say, hey, we're looking for these markers in our bloodstreams, and this is going to confirm that we've got ADHD. We don't have a ton of objective measures, but what we do have are behavioral rating scales, and behavioral rating scales are measures that are based on research that say typically within a normative sample, if we select out the people who present with these difficulties, they're going to say that they're experiencing these symptoms, right? And so we get people to do a self-report measure. We would get parent report of the same measure. We would get teacher report if it's a school-age child. For someone who's an adult, it proves a little bit more difficult. We need to know from their significant others. We need to know from their workplace, and we need their report. We just can't take a person's report of their own symptoms. Additionally, we've got to take into account that there's a lot of family and individual factors that are involved. So if a kid has been in a setting where they've been traumatized, they may be having a reaction to a traumatic stressor. And sometimes that reaction, those symptoms of hyperactivity, can look a lot like ADHD. And so the key is knowing that when that kid is out of that setting, there's a big change in behaviors. Other thing I want you to know is that attentional concerns can also be because of depression or mood disorder, right? You can have difficulty focusing because you're depressed. Anxiety can also make you more fidgety or restless. If you got a kid who's on the autism spectrum, they may have difficulty following through with a command, not because they have ADHD, but because there's something else going on. Additionally, early speech and language difficulties, learning disorders, and like I said, trauma or PTSD can complicate the picture. Okay, so what do we know is effective? We're going to have a good diagnostic interview, and that interview needs to be done by somebody who is licensed in clinical practice, right? And so across most states, that's a psychologist or a psychiatrist. It may also be a licensed clinical social worker, depending on the state. And that diagnostic interview is a structured interview that asks specific questions about development, about history, about current functioning. If the person is a child or adolescent, there'll be a behavioral class observation by somebody who the child does not know. You're going to try to get teacher or collateral feedback. So if a person is an adult who's working, their direct supervisor, etc. And then general symptom questionnaires or ADHD specific questionnaires. So in the school setting, you might get a questionnaire that's sent home that asks about attention in the home setting. We're also going to want some supporting evidence from psychoeducational testing. And what that is testing that's usually linked to learning differences. So an IQ test and a test of achievement, so that's school-based functioning, or neuropsychological testing, which is also done by a psychologist, but also measures executive functioning. And I'll talk to you about what executive functioning is a little bit later. So here's some misconceptions about how we diagnose, right? That you could just diagnose based on a prolonged observation of a kid or an adult. That's not it. That self-report will give us everything we need to know. No, that we don't have an objective test of symptoms. fMRI scan. So there is a clinic that posits that they can do an fMRI scan and tell you what type of ADHD you have. That research has not been replicated, and so I would caution you against that. We do not have an fMRI scan that can diagnose, okay, at this time that I'm aware of. No specific medical tests, testing measures, dietary changes. This is a big one. And so I have some parents who will come in and say, well, we're going to take gluten and we're going to take dyes out of the diet. The research is still in its infancy about the impact of dietary changes on ADHD. So a couple of years ago, there was a study that showed that there was certain food coloring that might contribute to symptoms, but we don't have anything conclusive. So I'm not going to provide an intervention that's based on that because I don't have enough data to support it. Okay, so I want you all to know just changing diet will not make symptoms decrease. And physical activity. So this would be the thought that you could run a person early in the morning and they'll get that energy out. Well, the studies around physical activity have shown that physical activity is good for everybody, but it won't necessarily decrease ADHD symptoms for kids who really do have ADHD. Now, with that being said, it might be helpful to have your child run in the morning and then go to school and take a break and be able to run and do some other physical activities. Or for you as an adult, you may know, I've got to get up, I have to run in the morning, then I can focus. And when I can't focus anymore, I run again, right? But it's not necessarily an evidence-based intervention. It just may be a tool that's helpful. Okay, misconceptions. So if they have ADHD, how come they can watch TV or play on the iPad for hours? That's called hyperfocus. So what we notice for people who struggle with attention is that they become hyper-focused on areas that are intrinsically motivating or internally interesting to them. The thing about the iPad and games that are electronic is you get a high level of reinforcement for very little input. So many of us can get sucked in. If you want to be able to kind of join with a person who can play the iPad for hours, think about how you do when you're on social media and you can just scroll and lose track of time, right? So we all have ways that we can become hyper-focused. How come they can sit through a movie without getting up? Well, that's high reinforcement for low input, right? You don't have to do a lot. It's engaging to watch the movie. How come they can sit through a meeting one day but not the next? Perhaps on the day that you caught them and they were sitting through the meeting, that topic was interesting to them. Or maybe they'd had a jolt of caffeine or a stimulant prior to that meeting, and that actually does the opposite of what it does for most people. It actually calms people with ADHD and helps them to focus. Maybe that's the case. So we want to know what external or environmental factors are in place that can contribute to behavior. Okay, so I want you all to know, everybody's presentation is not going to be the same. So variability is the rule, right? This is a disorder of attention modulation, right? It doesn't mean you can't focus at all. It means that sometimes your ability to modulate or to be in control of how you focus can waver, and you've got to put some things into place to be able to do so. And it's focused on when we're in dull, boring, repetitive tasks or tasks that require a lot of effort. Can we sustain ourselves mentally? Can we keep going? Okay. No, I've said a lot. If you all have questions, I believe there's a place in the chat to put questions and we'll get to those. So here's the thing. You can have a symptom but not experience an impairment. So just because I'm fidgety and restless doesn't mean I have ADHD if I'm not experiencing impairment in social or occupational functioning, right? So think about, how is this symptom impacting the person? If the symptom is helping me to complete my homework and get through my daily routines, then I'm not going to say that it's something that's problematic, right? But if it's getting in the way of these things, then we know that we need to implement an intervention. So many times when I see young kids who are presenting as very fidgety or restless, I'll say to a parent, I don't know that it's time for medication intervention. I think we can do some behavioral parent management training. We can set up some systems in the school or in the environment to address these things. When I get concerned is when kids or adults start struggling in terms of their ability to show what they know intellectually in the classroom setting. And that's when we, in the classroom setting or in the work setting, or when their relationships are being really impaired. And that's when we really want to make sure we implement an intervention. So, just some basic research findings. We know that the prefrontal cortex of the brain is implicated in the development of impulse control, and it matures later. And it's less active in kids and adolescents with ADHD relative to their typically developing peers. Okay. We know that it results in part from slow development of brain systems that are naturally linked to impulsivity. And more than 25% of youth with ADHD repeat a grade compared with their peers. This, I do not believe, is because of intellect. I think this is probably a function of the child not being able to show what they know in terms of standardized testing. I also think that in some school systems where they're been on the old school model where a kid hasn't matured and they want to hold them back to mature, that could be the case. There's not a lot of research that says holding a kid back to mature actually helps them academically. So we want to be aware of these things, okay? For adults, what I need you all to know is that this doesn't just pop up in adulthood, right? So as an adult, you've got to think back to you before age 12. Were you getting in a lot of trouble because you weren't following directions or following the rules? Did you constantly lose things? Were you fidgety and restless? Did you have difficulty focusing for long periods of time? Was it hard for you to remember your organizational system or parts of a routine that had been in place? Did you constantly need reminders, right? Those are the things that you're going to be thinking back to, and also getting information from your parents and loved ones about. What I'll tell you is that 45% of people who probably met criteria in childhood continue to meet criteria into adulthood. So this does not just go away for most people, okay? Or for about half of us. For adults, I talked to you all about those three factors: the inattention, hyperactivity, and combined type. For adults, what happens is it's like there's an executive functioning deficit, then inattention and impulsivity. When you hear executive functioning, think of the air traffic control system at the airport, right? So your brain has to manage multiple commands coming in and out of the airport, right? So you've got to be able to use your memory. You've got to be able to plan. You've got to be able to organize. You have to be able to tune out certain distractions that are coming in so that you can stay focused, right? So you've got multiple demands. So executive functioning is your ability to manage all of those competing demands and get through the day. Just like the air traffic control system at the airport has to manage multiple airplanes flying in, taking off, people getting stalled, etc., right? And so your inability to multitask or to be consistent in planning and organization is going to be really important in adulthood, okay? Some other findings, I'm not going to spend a lot of time on these, but teens with ADHD are typically more impulsive and more likely to get in trouble is basically what this shows. It's another reason probably that most kids are impulsive, and most insurance companies won't even allow children to rent cars or do things of that nature until age 25, because we know in terms of executive functioning that the frontal lobe of the brain has not completely developed until then. So imagine if you're a kid who has ADHD, in addition to just having the normal issues in terms of brain development, things are complicated, okay? How do we do intervention? What is the evidence-based treatment for ADHD? It is not individual therapy. It's behavioral parent training. I think I'm running out of time. Tamika, am I okay on time, or I'm sorry to stop abruptly, but
No, you're good. You're good. Just about maybe 5 more minutes.
Okay, I want to make sure we have time for questions. This is really important. Behavioral parent management training. What is it? It's a technique that teaches parents ways to promote behaviors. Okay, so one technique is using the positive opposite. So instead of telling people what not to do, you tell them what to do. So instead of saying stop running, you say walk. Instead of saying stop talking back, you say use correct language, use appropriate language. Instead of saying stop jumping, you say sit down. So the problem with saying no, stop, don't is that we don't tell people what to do next, right? And so for kids and adults with ADHD, you want to be specific, clear, concise, and give the to-do behavior. This is also a technique that we use in the classroom, coupled with a lot of motivators. So having a daily report card system, which is basically you set 2 or 3 goals for on task behavior. And every point of the day, you're giving that person feedback. And when I say feedback, I don't mean you're just saying good job. You're giving specific praise and letting that person know that at a later date, they're going to get some additional reinforcement. Specific praise is praising the behavior you like to see to get it to occur more frequently. I want you, I like the way you started work right away. Good job focusing. Thank you for listening, right? So we want structure, support, consistency, these things. Motivation, because we're struggling with motivation with ADHD, is struggling with intrinsic motivation to do tasks that you don't enjoy. We've got to put a lot of structures into place. I want to leave with this, and then I'll share some resources. As adults, sometimes we can be pretty hard on ourselves and hard on kids, and we'll say, well, I shouldn't have to pay you to do what you're supposed to do. What I'd like you all to know is that everybody needs a boost sometimes. We all need a little push to do better, right? So you get paid to go to work. If you didn't go to work, you wouldn't get paid, and you wouldn't go to work for free. When you're thinking about reinforcing kids for things that they should do, remember that we are building skills for a lifetime, right? And so even if it's something you think the kid should be able to do already, if you know that for that person, not even that kid, but that adult, that's an area of difficulty, then you meet them where they are and you give them feedback that encourages them. I like the way you tried that today. Good job remembering, okay? We're going to do a lot of planning ahead using powerful incentives, so having them work towards a goal. Feedback and consequences. We don't want consequences that are so big that a person can never come back. If you take away an iPad for a week, the kid will just figure out something else to do, or you'll be miserable because you need them to use that iPad when you're busy. So think about incremental removal of privileges so that you don't work yourself into a hole, right? So maybe taking it away for a day or for a few hours so that the person learns there is a consequence, but you also give yourself some grace. In terms of supporting organizations, there's CHADD for children and adults with ADHD. There's the ADDA, the Attention Deficit Disorder Association. These are some books. I can also share this information, and the PowerPoint can be shared. I have no problem with that. If you're looking to get treatment, though, check with your primary care doctor for referrals. Talk to employee assistance programs through your job, for your insurance company, your behavioral health coverage. You're going to look for your out-of-network behavioral coverage and your in-network resources as well. Go on the website for your insurance company. Here's some online resources. Online therapy is really big right now through the pandemic. We've learned that we have to be flexible, right? And there's some online psychiatry resources. For evidence-based information and care, I recommend these organizations, the American Psychological Association. For specific like strategies and tools, understood.org has amazing resources. If you got a kid who has an IEP or individual education plan, or you're as an adult, you're trying to figure out ways to work with your kids if you have ADHD and you suspect they do. And then childmind.org also has great resources available. Thank you all for giving me your time and attention, and I'm going to stop my slideshow with that.
Thank you so much, Dr. Carruthers. That was a fantastic presentation. I can just tell from the chat that this is definitely something that a lot of people are able to relate to, that the information is great. So thank you. So at this time, I'll check with question and answer. Do we have questions and answers for Dr. Carruthers?
Good morning. Yes, Soros, we do have some questions here in the chat. Before I present the questions, I want to just re-emphasize how to find the chat. People are having some problems. So I want you to go down to the chat and scroll through and look for the Q&A label. That is where you can send your questions. I have some questions regarding whether or not this is a program for certification and whether you will get points for attendance. This is not a program for certification. This is a program for information. So we will not be providing any proof of attendance for certification. Want to clarify that. So questions that are directed towards Dr. Carruthers. You did already answer one of the questions, which was, will the PowerPoint be available? And if so, can you drop a link to the chat that will allow people to access the PowerPoint directly.
Ooh, that's fancy, and I don't know how to do that. But what I can do is share it with the head of the Physical and Mental Health Committee and with Tamika so that it can be somehow shared.
Okay, thank you very much. So the next question is, it's introduced with the statement, Black women are often underdiagnosed with ADHD because we're taught to present as high performers no matter the setting. This leads to a perception that we couldn't possibly be struggling because we're able to complete certain tasks. How can we normalize conversations about Black women and ADHD?
Ooh, that is a beautiful question. Okay, how can we normalize questions about conversations of black women and ADHD? I think this ties to a theme that black women have to be super women, powerful, have be able to juggle multiple balls at a time and look flawless and have everything going for themselves, and that is also a myth. I think what we have to do is talk about not necessarily a label of ADHD, but more so symptoms or where you find it's difficult for you and where you find it's actually an asset, right? And so being able to be a little impulsive and be kind of quick in decision making can help you not miss out on some opportunities, right? So in some ways, it can really help you to take risks and to meet some goals. In other ways where you need support, though, it might be good to say, sometimes time management is not my thing and I've been struggling with it for a while. Would you mind giving me a quick reminder before X, Y, and Z is happening? Or when you hear somebody talking about being worried about their child or significant other with ADHD, helping them to normalize it by saying, hey, that's something I've struggled with, and I'm in treatment and I'm okay. Or it was really hard at this time and this is what I did. And so I think the more we are willing to share information with one another, the more we are willing to be open, the better.
Thank you. Thank you very much, Dr. Carruthers. The next question is, do you have any recommendations of adult executive functioning coaching therapy in the North Atlanta region?
I do not have a specific referral for executive functioning coaching. What I would recommend, oh, that is a hard one. Okay, so here's the thing. When you all are looking for providers, I think it's important to figure out what the methodology is that they're using, if it's evidence-based, if it's what the effectiveness is of it. And so that's when I would really kind of rely on Google, even though it's not my favorite thing to do. But checking with neuropsychologists, right? So doing a Google search for neuropsychologists in Atlanta and then reaching out to a neuropsychologist and finding out if they have specific executive functioning coaches that they work with, because neuropsychologists actually do the testing that lets you know what executive functioning deficits you're experiencing, and many of them do work with executive functioning coaches.
Thank you. I would also just follow up. You left some resources at the back of your PowerPoint about CHADD and the other support systems there, that they might also have some referrals for executive functioning coaches as well.
Yes, I'm putting those in the chat.
Thank you. If you believe your child has ADHD but was never diagnosed, can it lead to other mental health issues? And how do you get them to go in for a diagnosis? I'm assuming this was a child who is now an adult, and they're trying to figure out, if they were never diagnosed as a child, how would you encourage someone to go in as an adult?
Okay. This goes back to that stigma piece and people not wanting to have anything wrong with them. I think having a conversation with your child about what barriers were in place when they were a child that might have kept you from seeking treatment for them, being specific about what your concerns are now that they are an adult, and then giving them a resource, and you kind of have to go hands off. I think primary care doctors are a great resource for this, but sometimes as a parent, you gotta say, hey, this was something that was going on when you were this years old, and the teacher said this and this was happening and I missed out, and now I really want to give you this information because I'm worried that it's impacting you in multiple ways. And I have had parents of young adults, though, who were college age, get in touch with me in that way and say, I've convinced my kid to just talk to you one time. Can we just talk once? So maybe it's not a full course of therapy. Maybe it's, can you just talk to this person one time with me? You might have to hold their hand a little bit.
Okay. The next question is, if you just give me just, I have a 13-year-old who has ADD and is currently on Adderall. He has stopped taking it because he feels it is not necessary. How can we reinforce what his doctors suggest?
13?
13.
Oh, it's a tough time. Okay. So at 13, you can't force them. You know, they're at that age where he's decided he does not want to take it. But I think the question is why, right? Is it that it makes his stomach hurt? Is it that his head is hurting? Is it that he feels like his personality is not the same when he's on it? Does he think that he's different because he has to take it, right? You want to be clear with your kids about what the function of the medication is supposed to be. The function is supposed to be to help them concentrate, to help them focus so they can get through the school day, so they can experience less distress about work, or the function might be to help them so that they're not so impulsive that they make poor decisions socially and then they don't have friends. You've got to be clear with your kids about what the purpose of the medication was for them and finding out from them if that medication is in fact meeting its purpose. So for some of these kids, if they don't see a difference in any way, it could be that the dose isn't sufficient or that it's not the proper class of medicine. And so then they're going to push back, right? Or it could be, well, my stomach hurts every time and I don't like the way it makes me feel. We need to talk to the psychiatrist about that because perhaps that's not the right medication for you. So rather than throwing it all the way out the window, figure out what is going on with the medication that makes them not want to take it.
Okay. Thank you very much for answering those questions. We have a few more in the chat, but we don't really have time.
Okay.
So I'm going to direct the other questions to the frequently asked questions after the presentation. I do just want to give one quick resource that was dropped into the chat for resources, the National Alliance on Mental Health, NAMI, and the American Counseling Association, the ACA, which might also be another place to get some of your questions answered. Thank you very much.
Thank you all.
Thank you so much again, Dr. Carruthers. And welcome for all of you that are just now joining in. Thank you for joining our mental health webinar today on Mental Health Matters, Myths and Misconceptions. My name is Tamika, and I am the moderator for today's discussion. I did want to make sure to mention that, again, if you have questions, direct them to Q&A directly. If we aren't able to get to all the questions, we will definitely provide a total sheet with all of your questions and answers, like kind of a FQA. After the event, we will have those placed on our website or Facebook for you guys to review and get some answers to some of your questions. Today, we basically have a great panel of speakers who will talk about matters relating to mental health, from ADHD to eating disorders, anxiety and depression, and even how your faith can play a role in your mental health journey. I did want to make sure to mention to you that some of the topics discussed may provoke difficult thoughts and feelings. The presenters are not offering diagnosis or treatment of any mental health conditions during this program. But if you believe you have symptoms relating to any of the topics discussed, please make sure to consult a medical or mental health professional. Also, the information provided today and the views discussed do not represent Delta Sigma Theta in any form. This pandemic has been really hard on all of us. Most of us have felt the effects from grief due to loss, isolation, burnout, to simply trying to determine what our new normal is. So our goal today is to provide you guys with the tools needed to thrive and not just simply survive. So with that being said, I would like to move into our next presenter, Dr. Shan Whitsett. She is a board certified holistic health practitioner and certified nutrition and life coach with a PhD in psychology. For 30 years, Dr. Shan has worked with the Department of Defense in the Army Division. She works with soldiers to ensure their health and mental well-being is at its best. She has over 15 years of training in holistic natural health and healing nutrition, mindfulness exercise, coaching, case management, and social services. Dr. Shan offers ways to inspire individuals to make meaningful change in their lives using an integrated approach to mental and physical well-being. She has world-class residence training and uses the evidence-based strategies and proven techniques to help her clients. So with that, I will introduce to you Dr. Whitsett.
Thank you for that great introduction. I really appreciate it. Thank you. Great morning, everyone. I hope you're having an amazing morning so far. That was an excellent discussion from Dr. Carruthers. So now I just want everybody just to take a deep breath in and then release. And as I begin my discussion, I hope you listen with your heart and I hope you are refreshed. And this discussion is on awareness and educational purposes only. I'm not here to diagnose anyone. And as we continue with our health matters, we're getting ready to discuss mental balance and how to identify anxiety, which both are very important to our well-being. So as you sit here and listen to my discussion, I would like you to get a piece of paper and something to write with, because I'm going to be asking questions pertaining to yourself only. And it's just going to be some yeses and nos, and I want you to track your yeses and nos. So let me share my screen here. Okay, just a moment. Okay, so as we go through the agenda, and I'm going to do some highlights. I'm going to tell you what anxiety is. We're going to discuss some common symptoms of anxiety. We're going to take a look at some triggers. We're going to look at a short video. We're going to look at an example of the circle of anxiety with an example. We're going to talk about some common myths and some truths about anxiety. And then we're going to discuss natural techniques towards the end of this presentation. Like I said, the purpose here is not to diagnose anyone, it's just for awareness, so you can know what the symptoms are and what to do. So with that said, get your sheet of paper out, and I'm gonna ask you, this is a poll, so I don't know if we can see the percentages on the screen. If not, that's okay. I can look in the, we can take a look at the chat and see how many people know. Do you know what anxiety is? So yes or no. I don't know if we can we see the percentages on the screen? I'm not for sure if we can see that.
Excuse me, Dr. Shan, are you sharing?
Yes, I was. I thought I was sharing. Okay, let me, okay. I thought I was sharing. I'm going too fast here on this. I thought I was sharing.
Dr. Shan, is your green share screen button at the bottom of your Zoom screen? There it is.
Okay.
There we go.
There it is.
We can see it now.
I'm just here, just talking away. I'm sorry. Oh, okay. So we're on the slide on the poll check, and I was asking the question: do you know what anxiety is, and if we can see the percentages on the screen, or we can see it in the chat. I don't know. So the first question is: do you know what anxiety is? Either yes or no. And the second question is anxiety good, bad, or both? Okay, wait a couple of seconds because I see the numbers are still. Okay.
I set them up as two separate questions, Dr. Shan.
Okay. Okay, so.
So you can let me know when you want to end.
Okay, because I wanted to write down the percentages because I'm going to get the answers at the end. So, okay, so we can take down that poll and the polling. Okay. Okay, so we'll go to the next slide.
Oh, we don't want the second question. Okay.
Oh, I thought that, okay, yes. I thought that was already up. Okay, yes, the second question is anxiety good, bad, or both? Okay. I see the numbers still going, so I'll wait a couple more seconds. So we can tally those results. Okay, so we don't have any, so no, both, okay.
Both wasn't an option in the survey, Dr. Shan, unfortunately.
But we do have a lot of both in the chat going to Q&A. So we do have a lot of both in the chat.
Okay, okay, so I was just taking note of the numbers so we can test on knowledge at the end to see who was really paying attention. Okay. Okay, so we can take down that poll and I annotated the percentages. Okay, so next slide. So I can go ahead and take the poll question out and exit out. Can I do that? Okay.
You can go to your next slide.
Okay, thank you. All right. All right, this is not where we go now. Next slide. Sure. All righty. Okay, so what is anxiety? Anxiety is an emotion. It's also the reaction of stress, which causes mental strain. So when we talk about mental strain, think about the worry and fear that you have. So, okay, so, okay, you're talking about the mental strain. So it also has an effect on your body. Physical changes can also occur. As we look at the slide, there's 7 types of anxiety. So think of an umbrella. So under anxiety, you have general anxiety disorder, you have a panic disorder, you have social anxiety disorder, you have post-traumatic stress disorder, you have obsessive obsessive compulsive disorder, separation anxiety disorder, and phobias. So those are all under the umbrella of anxiety. But for this purpose that we're discussing today, we're only going to talk about general anxiety for time. So whenever you hear the term disorder behind a word, think of disorder as something that's constant. It's constant symptoms that's occurring daily, okay? So with the general anxiety disorder, statistics show that this anxiety disorder is among the highest in the United States among school-age children as well as adults. So as we look at some common symptoms of general anxiety disorder, keep in mind that this is not a diagnosis and that these symptoms that I'm going to be discussing, you might can have them, but it's a disorder, again, when it's constant and happening to you daily. So some common symptoms are listed here, and I'm not going to just read the slide to you, but just please be aware if you're feeling like you're having a heart attack, your heart is racing, sweaty palms, body aches, massive headaches. These are symptoms of anxiety. Also, if you're having, like I said, body aches, those aches are starting like from the top of your spine, and it also continues all the way down above your buttocks. So the main thing is if you're feeling like your heart is racing, you need to contact your doctor immediately. Don't let that pounding of your heart be persistent, because that is a sure enough sign that something is going on. So these are some common symptoms of general anxiety disorder. So let's take a look at some internal and external triggers of anxiety. I have 3 columns here. And so we're going to first look at internal triggers and keep aware that these internal triggers are triggers that are happening to you. So the first one is negative self-talk. What example of you can put in the chat, what can be a negative self-talk? I mean, if you're experiencing some internal triggers, what can that be? So I can give you also example. I can't do this. I'm not good enough. These are like negative words that you're saying to yourself. So the main one that I hear a lot when I'm mentoring is, I can't do this, I'm not good enough. The next one is an inability to accept the unknown. Example of that could be moving forward in a relationship, not going to work. Some more could be you just don't know what's okay with this COVID. It's just too many unknowns, and you're just stressing about it, and you're constantly thinking about it. Another internal trigger could be unrealistic expectations. One come to mind is females. We might say, hey, I want to be married by 35. I want to have a baby by this age. These are like unrealistic expectations that you're putting on yourself. And the last one is perfectionism. Example will be fear of failure. Everything has to be perfect in your world, in your internal world. These are internal triggers that you're putting on yourself. If we move on to the next column, we have external triggers as well. Work. Some examples, deadlines, staying late, family, kids, friends, relationship difficulties, financial problems. Most of the time, the external triggers are triggers that you can have control of. So let's go back to the example of work, staying late. You probably can control that and tell your boss, hey, I work from 9 to 5, staying after to 8. That's an external trigger. That's anxiety, stressing. I mean, this is a lot of mental stress. Kids, Relationships, being too busy. That being too busy is one that I see often. It might not happen to you. You might have people around you. Just think of their behavior and the things that they're doing, as that is a part of anxiety as well. Okay, so let's go to the last column, good anxiety. Okay, so there is good and bad anxiety. Some good anxiety could be the first day of school, you're experiencing some of those common symptoms that we discussed in the previous slide, where your hands could be sweaty, but yeah, you're happy, but you're experiencing some of those symptoms, but they will go away. So it's not a disorder unless, remember, if it's constant, consistent, daily. In sports, just the Super Bowl, I bet those guys were, going on the field. They had anxiety, but it was good anxiety. They probably was, heart pounding, going to the Super Bowl, that's good anxiety. So also getting your license. I remember when I was 16, I was like, oh my God, am I going to take this test and forget the signs? That's like mental stress as well. First date, first job, your first test, maybe getting married, even getting divorced can be good or bad. So as we look at these internal and external triggers of anxiety, what happens when these three columns, three areas that I just discussed are not balanced, it goes back to that stress, that mental strain leading to anxiety. So next slide. Okay, so we're going to talk about mental balance and anxiety. What does that mean? So mental balance, if you think about the psychological state, it's the psychological state of good judgment. Your emotional state is in a realm where your well-being, the results are your mind is free of pain. You're laughing. You can't be stressed and laugh. You can't have those two things going on. So you're realizing that it's potential in terms of wisdom. You're conquering your goals. These are areas when your mental balance is at a good stance, if you will. So when these things become unbalanced, you go back to those internal, external triggers. It can be a situation, it can be the environment, your diet. Just remember that anxiety is a reaction from stress. It's the tense worrying about everyday situations, good or bad. And it's only bad if it's constant and consistent daily. So our mental balance plays an important role in anxiety. So let's dive into what they're saying in the world about anxiety.
On the Medical Watch, the impact of COVID-19 on mental health.
Medical reporter Dina Baer puts the problem into perspective.
Emergency room visits for mental health issues have skyrocketed since the pandemic began. And doctors say the very rules to keep people safe from the virus are doing great damage when it comes to anxiety, depression, and even suicide. It spans the ages, and now everyone is suffering, but children are particularly at risk.
Emergency department visits we're seeing for mental health conditions among youth has increased dramatically.
They can't play with friends. They're not in school. Sports are canceled. And for young ones, it feels like their life as they know it is lost.
We know that children are facing increased social isolation and losses of their usual sources of support, such as their peers, their teachers, or their coaches. And many children are no longer able to access their usual sources of mental health care.
At Lurie Children's Hospital, emergency room physicians are seeing a 50% increase in mental health visits.
Every day we see at least 10 children or youth, if not more.
So while children are not getting as sick as adults with SARS-CoV-2, the virus that causes COVID-19, there is another contagion that is threatening them.
Children and youth are very much impacted by what's going on in their family. we hear a lot about how COVID-19 is impacting adults more than youth. And that's true in terms of their physical health. More adults are being hospitalized or dying from this pandemic. But really among youth, it's a mental health crisis.
Whether it's the loss of a family member or loved ones with building anxiety and depression, the weight of the pandemic is falling on children hard.
Children with underlying depression and anxiety may experience worsening of their symptoms. And we are unfortunately also seeing increases in teens with suicidal thoughts.
Doctors urge parents to look for the signs.
You might notice subtle things such as that your child is having difficulty sleeping. You might notice that they're tearful or just more stressed compared to their usual stress level. In all of those cases, a good first step, if you're noticing any warning signs, is to talk to your pediatrician.
Okay. Some takeaways from some takeaways from the current world video is mental health is becoming serious. It's becoming serious in kids and adults. We need to talk about it. We need to be aware about the symptoms and educate everyone. As I mentioned in the previous slides, one of the things is sleeping. So if you're up, not getting 7 to 8 hours of sleep, that's really a mental stress on your brain, because your body is not rejuvenating. So that was the first symptom they talked about in the video, that kids, if they're not sleeping, you need to watch the behavior of kids and adults. We all are experiencing all types of stress, mental strain from the pandemic. So with that said, let's take a look at some statistics. Over 90% of the population has experienced some type of anxiety, school age, as well as adults. Anxiety percentages are higher in women and less common in men. From studies, they're saying that anxiety in women, because we're more anxious, we are warriors, we have a different brain chemistry, fluctuations in our hormones, have our anxiety up more than men. Men are less likely to discuss their issues. There are over 3 million cases in the United States on anxiety, and under half of them are being not treated. And from my research and statistics, most people are scared to discuss anxiety. They don't have the money maybe to get help and don't want to be judged. Okay, so what are some potential anxiety questions. So if you get your sheet of paper out and something to write with, we can see where you are. These questions are pertaining to yourself. So we can take a couple of minutes and I can read the questions and you can annotate and keep these. And I'm going to give you the answers in the next slide, and you can keep your answers to yourself. These are only pertaining to you. So if you put on your sheet of paper, the first question, you avoid certain people. So just put on number one, yes or no. Do you avoid certain public places? Yes or no. Do you avoid unfamiliar people? Yes or no. So for the first question, you should have 4 answers, either yes or no. Number 2, do you consider yourself a warrior, meaning daily or often, especially about things that have no control over? Do you worry about past events? Yes or no? And do you worry about the future? Yes or no? So number 2, you should have 3 answers. Number 3, do you often feel like you're stressed out or on edge? Meaning, are you short-tempered, less tolerant? Does your heart race or beat often? Meaning daily.
Thank you.
So 2 answers to that question. Number 4, do you become tired or fatigued quickly? What about physically? Mentally? Yes or no? Do you feel your muscles tight or tense daily? Yes or no? So 4 answers for that question. Number 5, last question. Do you have problems concentrating and focusing daily? Okay, so total up your yeses and total up your nos. And then we'll take a look at what the total mean. I'll give you a couple of seconds to do that. Okay, next slide. Okay, so what does a total mean? So if you have 0 yeses, means you never said yes to any of these questions, you probably have 0 anxiety. So if you have 1 to 3 yeses, this means you said yes 1 to 3 times. You simply are dealing with a little stress at the moment. Maybe something has recently happened that caused you to worry. So if you have 4 to 6 yeses, means you simply are dealing with a little extra stress at the moment. Maybe something has recently happened that caused you to worry more than usual. So if you have 7 or more yeses, this means that you're experiencing some sort of anxiety that may lead to a disorder. Remember, disorders are only those symptoms that are happening to you constantly, daily, and that you need to write them down and maybe consult your doctor and talk to someone about that. So that's what those yeses and nos meant. Next slide. Okay, this is the cycle of anxiety, and I'm going to give you a real live example using the cycle. And this is a cycle that happens when someone is experiencing anxiety, which is getting ready to turn into a disorder. So I'm going to use the example of not going out the house due to COVID. So this is a real life example, and the person that has this still has it. And as we go through the cycle, what happens is the person, we're looking at the top, like think of a clock at 12 o'clock, and then where it has anxiety on the slide, it goes clockwise. So that red triangle is the danger zone. And so in that danger zone, what happens is that person is feeling, is avoiding everything. I mean, they're stressed out, excuse me, worrying, which grows to the result of fear. So this person's thoughts are, I'm going to get COVID, I'm staying in the house. I'm staying in the house so I won't get sick. I'm not going to the hospital because if I go to the hospital, I'm going to get sick. These are the thoughts that's in this person's head. Feelings, the feelings are fear. If I'm asking, what are you feeling? So they're feeling fear, panic, loneliness, of course, because staying in the house, avoiding to go outside because your anxiety is so overwhelming your brain that you're fear now, you're scared, you're avoiding things. That behavior then, as you move down, that person is running. So the behavior is not going anywhere, making up an excuse. Oh, I'll go to the doctor next month. So it's just a constant cycle. So that short-term relief of the anxiety is in that person's mind is, I didn't go nowhere, so I'll just get everything delivered, food, everything I need to get delivered. And as that person goes through that cycle, what happens is a relief of happiness. Stayed at home, I'm calm, but as you go to the circle, that message to the brain that person is given to their brain is that, oh, I came close to dying. If I go outside, if I go to the hospital, I'm gonna die. If I, come and contact people, I might die. So they're staying in the house. And what the brain thinks is, I can do this again. I'm in survival mode as I stay in the house. But what's going on is that anxiety is getting stronger and stronger. The fear is getting stronger and stronger. The worrying every day, headaches, body aches, frustration, and as this starts over and this is a continuous cycle. But the good thing is that person, sorry, I didn't hit the good thing is that person can get out this cycle. And the way that you can get out this cycle is, of course, getting out the house and talking to someone, or maybe even talking to your doctor, maybe talking to someone and doing like some natural stress. Maybe you're gonna walk to the corner just to get out the house, because you gotta relieve that stress, because what's gonna happen, the constant headaches, and it's gonna persist to something other than the anxiety. Let's get into some common myths about anxiety. So these are some common myths. I know there could be a slew of them, but I during my research and dealing with people who have anxiety, these are the common ones. So feeling nervous, meaning you have an anxiety disorder. And the next one, you are crazy if you are anxious and having, thoughts. These are all myths. Taking medication is a sign of weakness. No, it's not. Exercising, running, drinking natural teas, and relaxing is a cure. That's a myth. The last myth, alcohol is a perfect acceptance remedy for anxiety. This one, as I went through my research, it's a high percentage of women that are drinking wine to mask anxiety. So I had a couple of clients that are, I'm stressed all day at work. I come home with the kids. Once I give them their baths, homework, they're in the bed, I'm gonna have me a glass of wine. So they're masking their anxiety with the alcohol. So that is a myth that alcohol is a perfectly acceptable remedy for anxiety. And that's a total myth. So some common truths about anxiety, that everyone experiences anxiety at some degree. A person can't hide from it. A person who deal with anxiety issues overcompensate by being bubbly, talkative, and take care of others and not take care of themselves. That's where that self-care comes in. So you're constantly taking care of others, and you're not really sitting back to see what's going on with you. Always occupied, and it goes back to that perfectionism. These are just some common myths about, some common truths, about anxiety. So,
Hey, Dr. Shan.
how I'm doing on time? Okay.
We need to wrap if you can.
Okay. All right, let's wrap. Okay, so the next slide this is a natural, you can read this on your own. We're gonna put the link. This is a natural technique to reduce anxiety. The goal here is to see your palm. So you'll have your hand balled up. Usually, just think about a stress ball. So the goal here is to see the palm of your hand. You can read this later. We're gonna post our slides somewhere on our portal, so you can go through this. This is a really good natural technique. These are some more natural techniques that I use and some of my clients use. So I'll let you just browse through that. And okay, last slide. This is the answers to the question from the poll. Do you know what anxiety is? Hopefully now you should say yes, if you said no earlier. And is anxiety good, bad, or both? So whoever said both, you're absolutely correct, because it's both. This is the answer. And I'm sorry. Okay, in summary, I hope you have a great understanding of what mental balance and anxiety is. I hope you can recognize some symptoms and know where you fit in. And also, if you're not experiencing any anxiety, just look at the people that your circle, who you're hanging with, look at their behavior. Maybe you can help them. If you know of anyone who's experiencing some of the symptoms, have them consult their doctor. And if you're having suicidal thoughts, of course, contact 911 immediately. that concludes my discussion. And I guess we can put the questions in the chat, or we're going to answer them later and have them somewhere where people can go in and look at the questions, and we'll have the answers.
Right now, we don't have any time for questions, but I'm going to direct all of the questions to the frequently asked questions that we will display.
Okay.
Okay.
Okay. Okay. Thank you for your time.
Thank you so much, Dr. Shan. We wanted to just remind you guys as well that we have a link in the chat that's available for the survey. We would love for you guys to just take a minute and complete the survey. You can do it at the end, or if you need to leave the presentation, you can go ahead and just complete it prior to leaving. We will just continue to drop the link for you to complete it in the chat. So the next panelist we have today is going to be Dr. Judy Lee Webb, who will be discussing eating disorders. But just before Dr. Webb gets started, I would like to do a prize giveaway. So you guys, as we mentioned earlier, you have to be present to win. So I wanted to see if Simone Adderley is still in the presentation. If you could just maybe put a note in the chat, just to let us know you're here. Yay! Okay, great. So Simone is our first winner for our prize giveaway today. And we have a collection of mental health books that we would love to send you for some great reading. So if you could please send me a direct message in the chat with your email so that I can send you an email to get your mailing address so that we can put those in the mail for you. They are an excellent collection of books. I have been told what some of the titles are, and I think it'll be definitely some good reading. But thank you again for joining us. You are the first winner. So we will now move into the next panelist segment, which is again, Dr. Judy Lee Webb. Dr. Webb is a licensed psychologist in private practice here in Atlanta, Georgia since 2003. Where she conducts therapy with adolescents, adults, couples, and families, and provides trainings for organizations, universities, and schools, as well as supervision for mental health professionals. Dr. Webb is the founding president of IAEDP Atlanta chapter and is the first psychologist in Georgia to become a certified eating disorder specialist and supervisor. She is also a certified EMDR therapist used to help people recover from trauma and other distressing life experiences. Dr. Webb earned a Bachelor of Science in Psychology from the University of Florida, a Master of Art degree in Counseling Psychology from Howard University, and a Doctor of Philosophy degree in Counseling Psychology from the University of Georgia. Go Dogs! She completed her residency training from Medical College of Georgia and Augusta Veterans Affairs Medical Consortium and her postdoctoral fellowship training at the Atlanta Center for Eating Disorders, which is now known as Walden Behavioral Care. So with that, I will give it over to you, Dr. Webb.
Thank you so much, Sora Tamika, and welcome everyone. Thank you for taking time out of your busy Saturday to attend this program. This has been wonderful so far. Thank you to all the presenters. I've been enjoying it. So a little bit about myself and how I got into the world of eating disorders. As Sora Tamika mentioned, I went to 3 different universities to study psychology and never knew about eating disorders at all. Didn't really discuss it in my training programs. It wasn't until I was a student at the University of Georgia and I was working in the counseling center. And one of the students came in with symptoms of bulimia. And I had no idea what was going on. So definitely had to present it to my professors. And out of curiosity, I decided to do my dissertation on this topic. And as a Jamaican woman as well, of course, didn't really see this amongst, in my community at home or what have you, but certainly looking back, it was definitely there. So just wanted to talk a little bit about my interest in eating disorders and how I got involved. All right, so myths and misconceptions about eating disorders. One, that they do not exist in Black communities is a myth, that eating disorders only affect white, affluent women or adolescent girls, that people who struggle with eating disorders are all just trying to be skinny or thin, what have you, that dieting is a normal part of life, that's also a myth. Another one is that it's all about the food. People say things like, they should just eat, or they should just not eat as much. And then one of the common things I typically hear is, I wish I had an eating disorder. These are some myths and misconceptions. You know, even in the healthcare community, there's clinical bias. When presented with identical cases demonstrating disordered eating amongst white, Hispanic, and Black women, clinicians were asked to identify if women with eating disorders had a problem. And 44% identified the white woman's eating issues as a problem. 41% were amongst the Hispanic women. But when it came to Black women who presented symptoms of eating disorders or disordered eating, 17% of clinicians identified the woman's eating problem as a problem. So this is just showing that, once again, with the Black community, symptoms are dismissed, they're overlooked, they're minimized, and it's a great issue. It's a significant issue in the Black community. We are definitely not immune. This is the truth about eating disorders. We are not immune. Here are some statistics that I gathered regarding eating disorders. One is that they can affect anyone regardless of race, ethnicity, age, gender, culture, sexual orientation, religion, size, and socioeconomic status. A recent study shows that eating disorders have become a major health issue for Black women, even as recent of a study as 2019. There's an increasing evidence that the prevalence of eating disorders among women of color, including Black women, are similar to those amongst white Americans. Also, there's a study researching the prevalence of eating disorders amongst Black individuals, and it was found that African Americans may be at more risk for anorexia nervosa than Black people of Caribbean descent. And again, I included this one, and this was part of my research as well, and showed that, you know, in some Caribbean countries or just other remote islands like Fiji, for example, it wasn't until there was exposure to other cultures that folks started questioning their own eating issues or their own eating behavior and their own body image. So that's been shown in various cultures. Also, binge eating occurs at a higher rate amongst African Americans. Here's another statistic here. African American girls between the ages of 11 and 14 score higher than white girls of the same age in terms of behaviors attributed to eating disorders. Additionally, these same girls are more susceptible to binge eating disorder, a disorder that often goes undiagnosed. So I'm glad that we're speaking more about eating disorders. I mean, as a recent segment on the OWN network, you know, we all listen to Oprah, so she has a powerful platform. And there was a show called Sis Speak, and it was on physical health. And two questions were posed to the audience. One was, how many people in the audience have struggled with weight loss? A second question that the host asked was, who has struggled with body positivity and loving yourself just as you are? And again, I'm very happy that Oprah's even talking about her own issues with food throughout the years. Well, look at the answer, look at the responses here to those two questions. Look at how many women in the audience have their hands up, almost everyone, including the panelists. And here's our soror, Kim right here, you know, she has her hand up as well. So this is very common in the Black community. So just take some time to think about what negative messages have you received. I can honestly say when I was a little girl, whenever when we moved to America and I would go back home to Jamaica, I had a family member who would constantly comment on my weight, how much weight I had gained year to year or what have you. I think the only thing that really saved me from having any kind of disordered eating or an eating disorder was, one, thank God I have high self-esteem. And two, my mother never, the messages she gave me were all positive messages. So, can you imagine that what would have happened if I internalized these negative messages from this family member who would, she would say, Lord, you're fatty. I mean, she would just, it seemed like every summer I would go home, there was a negative comment about my weight. So here's myths and misconceptions again. Eating disorders are not serious. They're just a lifestyle, it's just about vanity. Some people even think eating disorders are a cry for help or a person just going through a phase. They'll grow out of it. They'll get out of it. Another one is eating disorders are just about people trying to be thin. Well, here's the truth. Eating disorders are psychiatric mental health illness. It's the second highest mortality rate amongst mental illnesses. So this is a recent thing where for the longest time, eating disorders had the highest mortality rate of all mental illnesses. With the opioid epidemic is now the highest, and eating disorders is the second. But for many years, eating disorders was the highest. More people die from them. Why? Because eating disorders oftentimes includes medical complications. People's hearts can just stop. It's years and years, especially with damaging your body in the way that people do with food or restrictive food, bulimia, what have you. Another unfortunate aspect of eating disorders is that oftentimes people die by suicide. Again, this is a mental health illness. It's extremely debilitating and distressing, and some people do take their own lives. So why food? What's the big deal with food? Well, why not food? Food is a part of our everyday lives. Food we've been taught that food can heal, soothe, comfort, numb our emotions, that we can control food, but food can also be abused, used as a distraction, used also as a protective mechanism. I've had many clients say that they overeat in order to gain weight, oftentimes due to abuse, especially sexual abuse, and they're trying to hide and make themselves unattractive or not for people to not abuse them anymore. Also, for many, food is a part of our identity, maybe our individual identity or our cultural identity. It's oftentimes used as a coping mechanism. So here are the type of eating disorders. And I'm just going to run through this real quick. You can take a screenshot of these slides if you've watched, just reference later on. But common types, anorexia nervosa, and that's when people restrict their food intake. They have a significant fear of gaining weight. They do different things, like with food and oftentimes exercise to have a thin frame. Binge eating, bulimia disorder is when folks may binge eat and then also try to purge their food. And purging food can be used through vomiting, excessive exercise, diuretics, laxatives, various forms of purging one's food. Binge eating disorder is when you eat a large amount of food in a short amount of time, usually within a 2-hour time period, and it's more food than one would typically eat. Folks feel uncomfortably full, they feel out of control, they feel disgusting, depressed, distressed, even shame. Oftentimes, binge eating occurs in privacy. Another one, and a more recent eating disorder, it's called ARFID, Avoidant Restrictive Food Intake Disorder. And this is when someone is avoiding food and then restricts their food, causing sometimes medical complications as well as social distress due to a fear. I've had clients who have had a fear of vomiting or a fear of choking or just a fear of the texture or discomfort with the textures of food. So they avoid certain foods, oftentimes then having some medical complications. And another big one is social complications. I've had clients who, when they're starting to date, especially folks in their 20s, or they're starting to do things with co-workers or what have you, or go off to college, and they're really realizing that they're starting to isolate because of their avoidance of certain foods, or they're just, again, their fears of certain foods. And the fears could be also medical, like I said. I've had clients who've had allergic reaction and anaphylactic shock due to food. So now they're really scared of eating not only the food that causes the allergy, but other foods as well. Rumination is when folks may regurgitate or chew and spit and then with the food. Pica is eating things that are not actually food, like powder or paper, soap, paint, ice. And then the other two disorders here is when somebody doesn't meet criteria for the first 6 eating disorders, but they do have some disordered eating. You know, folks have been coming, I've been really, I've been loving the transparency of many folks. I'm going to be showing some slides with people that we may all know. These are public figures. These are folks who, I am not outing them. They have come forward themselves with their own mental health and eating disorders. So the first one is Gabourey Sidibe. We may know her from Precious, the movie, as well as the show Empire. She has opened up about her own journey with bulimia and depression. Kerry Washington, best known for her role in Scandal. Many years ago, she opened up in People magazine about her history with an eating disorder when she was a college student, engaging in binge eating and excessive exercising. And then in Essence magazine in 2007, she reported that she used food to cope. So here are some types of disordered eating. So somebody may not meet criteria for an eating disorder, but there's many other types of disordered eating. And in the eating disorder community as professionals, we can identify these. Some folks may engage in emotional eating or compulsive overeating. Dieting. Dieting is not good at all. That's a disordered eating. Food restriction. Diabulimia. Diabulimia is when diabetics or on insulin mess around with their insulin in order to purge or get rid of calories. Drunkorexia. This is when folks, if they are going to be drinking, they alter their food intake because they know they're going to be taking in calories through alcohol. Pregorexia is when pregnant women, again, may restrict or do unhealthy behaviors such as excessive exercising or purging or what have you while pregnant. Orthorexia is another very common one when folks are engaging in what they call clean eating or really focusing on the purity of food. And again, it becomes disordered. Body checking, maybe checking yourself in the mirror quite a bit, or checking, measuring yourself or squeezing yourself, pinching your side, what have you. That's body checking. And then folks oftentimes have fear foods, foods they're afraid of, or foods that they consider safe. Now, I am a huge Janet Jackson fan. Actually have her book right here. I read the True You Janet Jackson book back in the day. And this is someone who has been open about her relationship with food and her body for many years. Janet has talked about, in her book, especially during her Velvet Rope days when she was working on that album, those videos, restricting her food intake quite a bit and engaging in this excessive exercise. And currently in her documentary that was on Lifetime this year, she has talked about how it has been as a public figure in the public eye, the pressures even from her second husband to look a certain way. Talked about being teased even by her brother about her body, and she called herself an emotional eater. And in the recent issue, the February 2022 issue of Allure magazine, she talks about trying to learn to love herself for her, loving her body and embracing herself. And then when in reference to body positivity and women who accept their bodies, she was referencing Lizzo and how it's so comfortable that Lizzo is comfortable in her skin and her size and being a full-figured woman. And Janet aspires to that. So I really appreciate her coming forward with her struggles. Another myth, men do not have eating disorders. So I'm going to show some images of some public figure males who have come forward about their struggles with an eating disorder or disordered eating in a bit. But despite the stereotype that eating disorders only occur in women, About 1 in 3 people struggling with an eating disorder is a male. And then subclinical eating disorder behaviors like the binge eating, purging, laxative use, fasting are nearly as common amongst men as they are amongst women. So here are some people who have come forward with their history of either an eating disorder or disordered eating. You know, we just saw Eminem in Super Bowl, and he talked about back in the days when he was restricting his food intake and excessively exercising. Zayn Malik is from the group One Direction. Elton John has been very forward about his battle with bulimia for 16 years. Dennis Quaid has talked about after having to lose a lot of weight for a movie role, he then struggled with his own body image and continued he was obsessing and counting calories and losing a lot of weight. We have Ashley Hamilton, who was in Iron Man 3. He has suffered with bulimia and anorexia. And then many of us know Richard Simmons from back in the workout jazzercise days. He's reported being a compulsive eater, using diet pills, laxatives, starvation, binging, and purging. Caleb Followill is the front man for Kings of Leon, and he talked about his history with anorexia as a teenager. And Tyler Oakley is a YouTube star, and he continues to have ongoing body image issues after an eating disorder as well. So Russell Brand, many of us know from comedy or movies, he has admitted to having bulimia and he attributes this to his low self-esteem. And don't judge, but I do watch The Bachelor, and just recently on The Bachelor, Clayton had talked about his history of restrictive eating after wanting to place. He was an athlete, but felt that he was overweight and started restricting his food intake. Speaking of athletes, Patrick Devaney, a former NFL player, talked about, again, we talked about the orthorexia. He was engaging in a lot of that clean eating, and his clean eating then turned into an eating disorder. And then Joey Julius was a player for the Penn State, and he came forward with his treatment for binge eating, as well as anxiety and depression. And then, one thing you've probably noticed from those slides, all of those were white men. But in a very recent episode of Blackish, one of my favorite shows, this is a February 1st episode of Blackish, Andre, played by Anthony Anderson, was in this episode. He was really worried about what he was projecting onto his kids, like the stress and whether or not he was a good dad. And Rainbow, his wife, found him in the closet overeating on cakes. He had a stash of some cakes in the closet. So Andre says to Rainbow, "Babe, do you think I've been using secret cakes as a way to soothe myself as I'm trying to control the natural emotions I'm pushing down?" And then Rainbow responded with, "Well, Dre, when Junior dropped out of college, you gave the bakery half your paycheck every month." Again, probably binge eating, buying a lot of food at the bakery. And then Andre then responds with, there was a lot of pressure growing up in my house where I was told to check my emotions because I was the man of the house. I always had a voice in my head making me feel bad every time I got emotional. Then, of course, he had to crack a joke, and he said that voice was his mother's voice. So this is, I'm proud of them for, again, portraying this. They're portraying people using food as a way to cope and a way to numb and bury their emotions. So I'm not going to go through all this. You can take a screenshot of this slide if you want, but here are a lot of the factors, a lot of the reasons. Why do people develop an eating disorder? Look at all of these stressors, these risk factors that play into how we feel about ourselves, how we manage stress. And, we talked a lot, before, even as a chapter, we've had presentations on strong Black women, trauma, discrimination, social cultural factors, even family factors, but medical conditions, self-esteem, so many things here. So take a screenshot of this slide. All of these factors play a role in developing an eating disorder. Other factors, the diet culture, we can't even go to the grocery store, right, when we're checking out without magazines talking about how to lose 20 pounds in 5 days. Just the generational family or cultural messages. We cannot ignore social media. And like I said, you know, in some countries when they started getting media, television, magazines, what have you, from the Western culture, hey, that's when eating disorders started rearing its ugly head in some countries. Unrealistic expectations, fat shaming and fat phobias, which I'm going to talk about in a second. Insensitive medical professionals. How many of us have been to a doctor? Well, again, we're weighed every time we go in. I tell my clients that you can tell them, I don't want to be weighed, or they can be weighed backwards or hide the number on the scale. But, you know, some of medical professionals can be insensitive about how they talk to people about their weight and their body. Bullying, teasing, shame, embarrassment, and feeling unsafe or powerless. So other psychiatric issues, most of the time, my clients don't just have an eating disorder. They have other issues going on as well. And I'm going to move quickly through these slides because I'm running out of time here. Tammy Roman just spoke about body dysmorphic disorder, which can oftentimes lead to an eating disorder. She, at the age of 13, in her quest to be a model, started restricting her food, purging through vomiting, and even had her mouth wired shut. This all because she did not see herself the way it really was. She had body dysmorphic disorder. Here's a book that talks about fat phobia. And again, fat phobia and weight discrimination, it occurs in so many areas of our life. And here's a list of areas where it occurs. But I am so proud and so happy that there's a body positivity movement, and people are really becoming vocal about accepting oneself no matter what your shape and size. And Nicole Breyer, comedian and actress, is very vocal on body positivity. Here's just some other pictures I grabbed from, about body positivity as well. Serena Williams, bless her, she is awesome. Love Serena Williams, and she talks quite a bit about the shame, the body shamers out there, and that how she and her mom are so vocal about women loving their bodies and their curvy, strong, muscular, tall, short, what have you bodies. And she is definitely focusing on that, especially as she has a daughter now. You may hear terms like health at every size. That's a term where, as health professionals, we focus on weight inclusivity, just encouraging people to engage in healthy enhancements, respectful care, eating for well-being, and just, you know, a lot of folks don't like exercise, but I encourage my clients to move their bodies. Here's another body positivity person, yoga instruction, Jasmine Stanley, love her. Trying to forward the slide here. Okay, myth is you can't recover from an eating disorder. That's not true. Recovery is very possible. These are the areas where people, you know, they improve their relationship with food in their body. They stop these disordered eating behaviors, challenge their negative thoughts, have a healthier core belief, self-love, self-compassion, body acceptance, and also body neutrality. Some people may not end up loving their bodies, but they can be neutral as their bodies. Like, I respect my body, and I love that my body allows me to move, and also taking back control. There are different forms of therapy that can be used to treat eating disorders, in addition to general therapy, then psychiatry for medication, nutrition counseling, treatment programs, and adjunct therapy like equine therapy and what have you. Here are some more stories that I'd love to share. Again, take a picture of this. Stephanie Covington Armstrong talks about her own journey with an eating disorder, and she's a Black woman, and there's a filmmaker. She's of Jamaican and Guyanese descent. She has a film on Amazon Prime. It's a depiction of her own history with bulimia, and if you have Amazon Prime, I'd encourage you to check out that movie. Here's a local doctor here in Atlanta, Dr. Frida Milhouse Jones. I met her several years ago when I was on a panel discussion, and she came up to me, and this story is in YourTeenMagazine.com. She wrote an article recently. She came up to me and said, do eating disorders really exist in the Black community? I really don't see it in my patient care. Unfortunately, sadly, after that, you know, her own daughter had an eating disorder and had to, and is now in recovery from an eating disorder. And so Dr. Frida Milhouse Jones now treats people with an eating disorder. And she's very quite vocal about it. And I'm so happy to connect with her on working together with clients with eating disorders. So you can read her article here. And again, people opening up about mental health and therapy, which I'm loving. Black people, and Taraji P. Henson has a Facebook program. Tamar Braxton has come forward about her struggles with mental health. Here's some more folks right here. I'm going to move quickly through these slides. Love TJ Holmes. All right, so I'm just moving through more folks. Here's an eating disorder professional network, a group of us working towards eating disorder treatment. A chapter I wrote in a recent handbook on eating disorders, and podcasts. If you're interested, you can go to this podcast. I'm talking more about eating disorders there. And that is it. That is it. Thank you so much, everyone.
Thank you so much, Dr. Webb. That was a fantastic presentation. And I think, during this pandemic, we can all relate to, disorders in eating, being stuck in the house and dealing with emotions. So thank you again so much for that. I will move into our next presenter. And I just want to remind everyone that, this is a no judgment zone. I know it was mentioned earlier, but, it's okay to not be okay. We haven't always been in a space where people were open to discussing mental health, whether you have experienced mental distress or are in the midst of it, or just simply know someone who has. We really hope that today we're able to provide you guys some insight and, more importantly, keep the conversation going. Okay, next we have Dr. Hamad Ensho. Dr. Hamad Ensho is a licensed psychologist and executive director of the Ensho Behavioral Group, a New York and Georgia-based psychotherapy practice service, frontline trauma response, and global behavioral health consulting firm. Prior to founding the Ensho Behavioral Group, Dr. Ensho served as a behavioral scientist in the Elite Epidemic Intelligence Service of the Centers for Disease Control and Prevention, where he deployed internationally with outbreak rapid response teams. Dr. Ensho also served in the Medical Service Corps of the United States Navy, where he completed a clinical psychology residency at Walter Reed National Military Medical Center. Dr. Ensho was appointed Assistant Division Officer over the Navy's largest trauma treatment clinic and served in the Navy's disaster response team. Dr. Ensho is an award-winning lecturer and has taught courses in cross-cultural psychology, interpersonal relations, and public policy at the undergraduate and graduate levels. Dr. Ensho is a graduate of Morehouse College. He completed master's level training in clinical psychology, cross-cultural psychology, and behavioral economics at Columbia University, Cornell University, and Rensselaer Polytechnic Institute, respectively. He completed his doctoral training in counseling psychology at Boston College. Thank you so much for being with us today, Dr. Ensho. It's all yours.
Thank you so much for the invitation. I greatly appreciate it. I'm going to be presenting today on a topic near and dear to myself and to the work that I do. So good afternoon, everyone. I am, as mentioned, I'm Dr. Hamad Ensho, and I'm a psychologist whose practice tends to work with a lot of men and as such focus on men's mental health issues. So my contribution to today's discussion will be broaching the topic of mental health within the context of Black masculinity. And as the topic of mental health of Black men and boys is a vast and multifaceted topic, I decided to focus on one specific area, that being emotional expression. Now, I am actually a historian at heart, and although I'm a psychologist, I actually majored in history at Morehouse, not psychology. So in conversations such as these, I often start with a historical anecdote to try and frame the discussion. And so for today's discussion, I turn to the life of Henry Box Brown. Now, many of us may know of the historic and the heroic story of Mr. Brown mailing himself to freedom. But what we may not know is actually the context. And in mental health work, context must be considered in order to understand behavior. So, Mr. Brown was enslaved in Virginia. And in 1849, he was married, had 3 young children, and his wife, Nancy, was pregnant with the couple's 4th. But before she would give birth, however, Nancy and her 3 children were sold off out of state, and Henry would never see his family again. In his despair and to escape that trauma, Henry climbed into a box. And for the rest of his days, Henry made a living as a performer and entertainer, often regaling white audiences with reenactments of his escape. That is how he processed his pain. A historian once noted that in a way, I don't think he ever actually escaped the box. But why am I even talking about a man in a box? Because in many ways, due to the contemporary conceptualizations of masculinity in general, and Black masculinity in particular, like Henry Brown, Black boys and men often exist within a box, an emotional box. But what exactly do I mean by this? What do I mean by Black males actually existing within a box? Well, let's start with boys. Now, when discussing this box that Black males exist in, I like to examine it from 2 alternate perspectives. The first represents forces that are external to the home. So for example, studies have demonstrated that in schools, Black boys are perceived distinctly differently from boys of other racial and ethnic backgrounds, and as a result, are subjected to discipline and policing at rates much higher than their white counterparts. The most frequently used discipline technique implemented is suspension or actually expulsion from the educational process. And such disciplinary actions put students at a higher risk for negative life outcomes, including involvement in the criminal justice system, for example. And those punishments can damage the student's perception of their school, of performance in school, and negatively impact their academic success years later, which, as we know, is tied to subsequent social economic status. So the message that is communicated to boys is, you, young Black boy, are different. You are a problem. Okay, so this represents a sampling of forces external to the community that work to keep Black boys boxed. But there are also messages within our community that work to keep Black boys in a box that are arguably just as hurtful. These messages that the boys receive are from family or for friends or influencers within the neighborhood. Messages such as, you, young Black boy, cannot express a full range of emotions. The boys are used to hearing things like, stop it, stop crying, be a man, which is, actually kind of ironic. It's an ironic message, given that outside of the community, our boys are frequently viewed as adults and treated as adults and not the children that they actually are. Or boys are told, stop acting like a girl, which serves to plant these early seeds of sexism and patriarchy. And of course, existing within this emotional box has consequences.
The idea that it's not okay to express their emotion is not working, and it's playing out later in life. It's causing them problems. It's causing inability to achieve, inability to thrive, inability to be in a positive relationship because we're emotionless.
So our young men experience pain and don't feel that it's okay to express it, or don't even know how to express it, haven't been taught, haven't been instructed on how do I express and process these emotions that I'm experiencing. And this is not a trivial issue, especially when we realize that the suicide rates for Black children is twice that of their white counterparts. And of course, as mentioned in this video, this inability to process emotions eventually has downstream consequences as boys mature into men and pursue relationships. And, as discussed with Black boys, in my work with Black men, challenges encountered also tend to come from two directions. Those coming from outside the community, and again, those presenting from within the community itself. And we know what these messages are. We know these messages about Black masculinity that come from outside the community. These messages, it inspires purses to be clutched tightly in elevators. Black men are viewed as predators, as threats to safety that must be violently addressed. They are and have historically been viewed as a specific stereotype known as the brute. I've always felt that the main character in one of my favorite novels, Ralph Ellison's novel, Invisible Man, describes this experience best. He writes, "I am an invisible man. No, I am not a spook like those who haunted Edgar Allan Poe, nor am I one of your Hollywood movie ectoplasms. I am a man of substance, of flesh and bone, fiber and liquids, and I might even be said to possess a mind. I am invisible, understand, simply because people refuse to see me. When they approach me, they see only my surroundings, themselves, or figments of their imagination. Indeed, everything and anything except me." So we know this experience well. We have fought back against such perceptions of Black masculinity since first landing on these shores. But at the same time that Black males are contending with forces directed at them from outside the community that places them within a box, they simultaneously face forces within the community that serves a similar purpose. As I mentioned earlier, boys are raised into men with messages that men have to be tough, have to be strong, that men do not show pain, that pain, in fact, is weakness, and that men do not experience fear. And if you do experience these things, you eat it, you push it down, you keep it moving, and you definitely do not talk about it. But of course, despite this socialization, despite these Herculean efforts, men are just human beings with a full range of emotional expressions and emotional experiences. And denying or arresting this can prevent us from forming vulnerable and authentic relationships. Further, to focus on my own work, my own area of specialization, trauma treatment, which is trauma treatment specifically, studies have identified that 62% of Black males have experienced a traumatic event at some point in their lives. This is both through witnessing trauma experienced by others, and this usually takes the form of domestic violence, witnessing domestic violence in their home, or community violence within their neighborhoods, or they experience trauma through direct exposure. So for example, Many studies have identified that 1 in 6 men report to have been sexually abused as a child. And actually, that number is assumed to be an undercount due to the fact that men often will underreport and will not talk about the sexual abuse that they experienced as a child, which of course can all lead to PTSD, post-traumatic stress disorder. But then here's the question. How does one work through any of this when you don't have access to your feelings, when you don't have access to pain or hurt or sadness? How do you process any of this? Well, frequently you don't. And instead, you just express the one emotion that is deemed acceptable, anger. And one thing also that we know is that hurt people, which in part is reflected in the trauma exposure that experienced by women. The overwhelming majority of their trauma exposure is caused by men. And as we see here in this graph from a Harvard School of Public Health study, Black women were identified as having the highest proportion of PTSD among all groups studied. But back to our discussion of this box of Black masculinity. In so doing, we also need to discuss intersectionality. Intersectionality examines how multiple social identities, such as race and gender and sexual identity, for example, intersect on a personal level to reveal interlocking social structural inequalities. So for example, same gender loving men or men of trans experience, for example, contend with their experiences of being Black, of being men, while in addition, experiencing unique inequalities such as lack of support or outright rejection from family and community members. They often experience a hesitancy to display affection towards their loved ones publicly out of concern for reprisals, and thus, as a result, are placed in an even more confining box. And this is also true for boys who have much less agency over their lives than their adult male counterparts. And of course, all of this can lead to challenges in mental health, such as depression, anxiety, or suicidal ideation. So it brings us to the question of, well, what do we do to get our men out of this box? Well, obviously, we continue to contend with and resist forces external to the community that seek to place Black males in a box. We continue to push back against institutions such as schools that attempt to place and keep Black boys boxed. We must and we will resist and fight these forces just as we always have. But at the same time, there's also work that we must do, that we as a community must do. If our sons, our husbands, our brothers, the men in our life, the boys in our life are to live free, unboxed, emotionally healthy lives.
It's okay to be vulnerable. It's a safe space. But our boys need to know that the family is a safe space. Look, I'm your father. I'm a safe space for whatever it is that you're thinking, whatever it is that you're feeling. It's a safe space for you to express it. And we're gonna work it out. Why? Because I love you. I love you. First.
To the men with us here today, brothers, we have work to do. We must do the work, the hard work, to access our emotions, and feel comfortable doing so that we can more effectively engage with ourselves and with those that are in our lives, with others that are in our lives, and to the community as a whole. We must endeavor to change our conception of masculinity so that Black males can live freer, healthier, unboxed lives. Thank you.
Wow, Dr. Insho, thank you so much. That was a wonderful presentation. Definitely something I know that we can all relate to, whether it be for husbands, brothers, friends, cousins. So thank you so much. I would like to ask each of the presenters if you could put your email or information in the chat. We have had a couple participants requesting a way to just reach out and get some additional information from your presentations. We will also have time at the end of the presentations for Q&A. So if you could just hang in there with us, we will get to those questions after the final presenter. So with that being said, I would like to introduce our next presenter, Dr. Valdacia DeJean. She will be talking with you guys about depression in general. Valdacia DeJean is a board certified psychiatrist who received her medical degree from Meharry Medical College and completed her residency training at Baylor College of Medicine's Menninger Department of Psychiatry, where she served as the first Black female chief resident. She received the Rafael Hernandez MD Award for demonstration of excellence in clinical psychiatry and related research from Meharry Medical College. She was also the recipient of the Distinguished Laughlin Fellow Merit Award and was recognized as the Distinguished Fellow of the American Psychiatric Association. Dr. DeJean previously served as a clinical assistant professor at Baylor College of Medicine in Houston, Texas. She is one of the co-authors of the book entitled Professionalism in Psychiatry. She is also a public speaker and mental health advocate who is committed to the mission of decreasing stigma and health disparities associated with mental illness through community education. She has been featured on 11 Alive News and podcasts such as Therapy for Black Girls. She is currently in private practice at the Georgia Psychological Treatment Center in Marietta, Georgia. Dr. DeJean, thank you so much for joining us. We would love to hear from you.
Some call me a spirit. Some refer to me as a nervous breakdown. Some even consider me to be a chemical imbalance. Regardless of my name, my presence is potent and even disruptive. I can change the nature of one's thoughts and cause one to have a negative outlook on life. I have the power to entrench your mind and cause disruption of your ability to focus. I can keep people up at night or have them sleep all day long. I even contaminate the healthiest of appetites, causing one to lose weight and sometimes become unrecognizable. My weight is heavy. I can deplete your energy and drain you of the motivation and drive to engage in the pleasurable activities of life. I am able to shatter one's hopes and dreams and throw them into an abysmal pit, having them to believe that life is not worth living. I am jealous of my victims' friends and family. When I am with my victims, I like for them to alienate themselves because I want all of their attention. Some of my victims try to conceal my existence. Perhaps they are afraid that if others recognize me, they will be judged, ridiculed, or even stigmatized. What these people fail to realize is that I don't discriminate. I I have tortured the poorest of the poor and the richest of the rich, both young and old, people of all races, all genders, all religious faith, all doctrines and creed. At times, my victims turn to their spiritual community to seek help. Some of my victims don't even attempt to seek the counsel of their faith leaders because I make them feel so ashamed. They fear that they will be criticized or maybe even told that they lack faith in God. Some people tell my victims to just pray me away. Some are encouraged to seek help with mental health providers, but others are discouraged. You may be wondering, what is my kryptonite? Well, it depends on how entrenched I am with my victims. I can tell you this. The more interventions you propel at me, the weaker I become, and the more I am likely to retreat. Who am I? My name is depression. Hello, I am Dr. Valdacia DeJean, and I have the honor and privilege to speak to you today about a topic that couldn't be more important during these challenging times that we are living in. I wrote this monologue with the intention of educating about the symptoms of depression, while also exposing the myths, misconceptions, and overall stigma associated with depression. It was my goal to evoke an emotional experience to enhance the learning process. Because from my experience, if you have an emotion connected to something you're learning, it's more salient and it's more imprinted in your mind. I'm curious to know what came up for you in that moment with this character in the monologue. Did you feel sad? Did you feel scared? Did you feel anxious? Did you begin to think about a loved one who you know struggles with depression? Or maybe you felt reminded of your own time in your life, a moment of despair. And if you did think about yourself in that way, during that moment of despair, or that time frame in your life where you might have been depressed, did you seek help? And if not, what were the barriers that kept you from going into the office to see a therapist or psychiatrist? As a psychiatrist and psychotherapist, I must say that even when people are courageous enough to take that first step to come into my office, I am often in the position of having to process the myths and misconceptions that are interfering with the treatment before the real work can begin, because there's so many barriers and resistance that's already there. So allow me to share some of the common myths and misconceptions that I hear from patients that we have to work through. One of the most common things I hear is, I'm being punished, I'm under satanic attack. The issue with this narrative is because many people describe, as illustrated in the monologue, depression as a spirit. That narrative may be getting in the way of people getting the help that they need. What I would offer today is to reframe depression as a biological illness that has psychological, social, and spiritual implications. Now, what do I mean about spiritual implications? What I mean is that there are things that can make you vulnerable to depression as it relates to spirituality. So let's say you're going through a spiritual crisis, or you're struggling with your existence and what the purpose of your life means. Or maybe you're wrestling with, is there a God? Those things can lead to vulnerability to depression. On the contrary, on the other side of things, there are factors that promote resilience from depression: spiritual worship, meditation. So those are protective factors. There are also the issue of unchecked psychological rooms becoming a vehicle for transgressions, because we have not addressed our own demons in that we haven't addressed our own issues. But see, that gets interchanged so much that we start saying that depression is a spirit. So I am under satanic attack. I'm being punished. So let's look at the further implications of that. So if I'm saying I'm being punished, does that mean you don't feel like you deserve to be happy? And how does that impact how we engage in treatment? If you're ambivalent because you don't feel like you deserve happiness, then you may not invest in your treatment. Here's another one. My mother told me that I don't need medication, that just pray for God to heal me. One thing I offer to patients, don't put God in a box, because there are vehicles in which God heals. Sometimes he heals directly through miracles, and there are other times where he heals indirectly. I tell people, perhaps he wants you to go into the office with a therapist or psychiatrist because he wants you to identify a pattern that you're engaged in that's unhealthy, that he wants you to learn to interrupt, that God uses vessels for healings. Another common statement is, I am a bad Christian because I'm depressed. Somehow we've equated morality with depression rather than seeing it as a biological illness. See, people also see it as a sign of strength. If I take this medication, that means that I am weak. Or I don't think I'm at risk of depression because it doesn't run in my family. That type of notion can actually be very dangerous, because then you're not putting the proper safeguards in place to protect yourself from depression. It also can perpetuate stigma because you have this psychology of invincibility. So you set yourself apart from other people and may come across as less compassionate or judgmental. Number 6, my culture and my family doesn't believe in depression because Black people don't struggle with that issue. We are strong. You can insert Indian, Asian, Hispanic. I hear this a lot from minority groups. This pressure to live up to this prototype and standard of strength is crippling us at our knees as a community. And lastly, people say a lot, I was told that it's all in my head. So what that causes is an issue with feeling like you can reach out for support. You feel like you have to will yourself out of the depression. So depression can manifest in very different ways. The monologue illustrated symptoms of major depressive disorder, and that's what we commonly think about when we think about depression, but there's also bipolar depression. With bipolar disorder, patients may have extreme opposite episodes, one where it's depression symptoms, and the opposite of that would be mania, where there's extreme elation or euphoria. Sometimes it's extreme irritability and their increased energy and things of that nature. So that's another way that it can manifest. Schizoaffective disorder is a psychotic depression, and people have lost sight of reality with this illness, and they may have hallucinations or delusions. And so that psychotic depression is called schizoaffective disorder. Persistent depressive disorder is when someone has a long-standing history of low-grade depression or dysthymia. It may last 2 years or more. They just don't feel the zest and joy out of life. They're able to function well, but it still can be very debilitating for their livelihood in terms of connecting with others. Sometimes depression only happens in the winter and fall months, and that's called seasonal affective disorder. It's associated with the sensitivity to light or having lack of thereof. Depression secondary to another medical condition. That is when medication sometimes or other illnesses can lead to depression, like hypothyroidism, vitamin D deficiency, and anemia. So sometimes just addressing the medical cause can alleviate the symptoms of depression. Premenstrual dysphoric disorder is a type of depression that happens around the menstrual cycles for women. And although it's transient and happens just once a month, patients with this illness can get extremely irritable, and they can have impairment in their social and interpersonal life because of this illness. Sometimes substance use like opiates and alcohol can cause substance-induced depressive disorder. And there are times when you can have a depressed mood but don't have very severe symptoms of clinical depression, and we call that an adjustment disorder with depressed mood. During this pandemic, there are probably a lot of people who might have met criteria for this, because we were having this huge life stressor that we were having challenges navigating. And there are occasions when you're depressed, but you don't fit in any of these categories discreetly. And so in that situation, we call it unspecified depressive disorder. So as the monologue illustrates, you can have depressed mood, lack of interest in pleasure and activities, insomnia, fatigue. When it becomes more severe, you can have suicidal thoughts or morbid thoughts about death. And if it lasts more than 2 weeks, then you technically meet criteria for major depressive disorder. As I mentioned, in bipolar disorder, you can have an expansive mood with 3 or more of the following symptoms: increased self-esteem or grandiosity, lack of need for sleep, which I want to make the distinctions that's different from insomnia. It's the lack of need for sleep because you're so energized. You can be more talkative. Your mind is racing a mile a minute, having goal-directed activities. You can become more impulsive to the extent that it interferes with your life or your consequences. So there's 2 types, bipolar 1 and 2. I'm going to wrap up here: mania and hypomania. Here are some non-pharmacological interventions for depression. When you do have moderate to severe, sometimes this is not enough to suffice, and you need to get more. One common myth and misconception with herbal remedies is that it doesn't cause side effects. That's not necessarily true. So there are clinical studies that suggest that these pharmacological interventions, there's trials, they've been more well studied than a lot of the herbal medications. If you know someone that's struggling, ask them what they need. Offer to take them to a provider and tell them about your own depression if you struggle with it yourself. Let's stop colluding with stigma by being silent, because the silence perpetuates stigma. I've listed some resources here so that you can know how to support and find a new provider. And most of all, if you are yourself struggling, you know you need to help. Know that it's okay to not be okay. There are people willing to help you. And I'm going to leave you with a quote by the novelist Anais Nin. She once said, "And the day came when the decision to remain the same was more painful than the risk to evolve." Take the risk of vulnerability. Take the risk of judgment. Get what you need. Thank you.
Wow. Just wow. I don't even really have the words, but thank you so much, Dr. DeJean. That was a wonderful monologue. I mean, I think we need to add a new Oscar category if possible. That was amazing. Thank you so much. We do have one final presenter, and I wanted to just give you guys a quick reminder that we are putting the link for our survey in the chat. If you could take a moment to fill that out. If you won't be able to stay on till the end, just fill it out as you're leaving. Again, we will have the Q&A at the very end. We'll have a few minutes. And if not, if we can't reach all of your questions, please feel free to place them in the chat. We will be going through and making sure we get you answers to your questions, and it'll be placed online for you guys to view in a summarized format. So again, our next and final presenter, it's Reverend Dr. Boger, who will be speaking with us about faith and mental health, how our faith can affect that journey. Pastor Eugene Boger, also a graduate of Morehouse, is serving in his 6th year as senior pastor of St. Paul United Methodist Church and St. Elizabeth United Methodist Church in Meridian, Mississippi. He is completing his Master of Divinity at Gammon Theological Seminary at the Interdenominational Theological Center in Atlanta, Georgia, with a concentration in pastoral care and counseling. Reverend Boger presented recently at the Minority Health Conference hosted by the National Alliance on Mental Illness. Eugene has hosted a series of webinars on church and mental health. In addition to the host of awards and pastoral appointments, most recently in the Mississippi Conference, St. Paul UMC, under the leadership of Reverend Boger, received the One Matters Discipleship Award from the Discipleship Ministries of the United Methodist Church. Reverend Boger is passionate about the intersection of church and mental health and introducing innovative ways to engage in ministry that result in salvation, faith development, and church growth. Reverend Boger, thank you so much for joining us.
All right. Thank you all very much for giving me the opportunity to share during this the webinar. As already mentioned, my name is Eugene Boger, and just grateful for this opportunity to have this conversation, and grateful for your chapter for taking a leap and sharing on this very important subject matter. So I want to try to accomplish a few things. One is to kind of explain why I'm here, why we are here. I would like to provide a historical perspective on this intersection of mental health and faith. And I would like to offer an apology, and then provide to you the institutional and even individual perspectives and responses. And if we have time, some resources. So first of all, by way of introduction, my first responsibility is to stay in my lane. I am not a clinician, and you have received sufficient information from a clinical standpoint, those who are licensed practitioners, and I hope that you truly internalize and absorb the information that has been provided to you today. My lane is the intersection of the church and mental health, and particularly my context is the Black church, and so that's the lane that I'll try to stay in. Unlike most drivers in Atlanta, I'm going to try my best to stay in my own lane and successfully complete this. So here, by way of introduction, I have been pastoring for over two decades, and that's one of the reasons why I'm here, that I strongly believe in this intersection of mental health and faith, and that they are not adversaries. That mental health and faith are not in competition, but instead they are working hand in hand, and we'll unpack that a little bit more. I'm also here because my own personal mental health journey as clergy, as an African-American male, as father, as one who has gone through divorce, in the midst of pastoring, as one that has dealt with issues of identity and stigma and depression. I am proud to confess that as a clergy, as pastor, I have Jesus and I have a therapist. And I believe in being true to the text that calls for us to love the Lord with all of our hearts, with all of our soul, with all of our mind and strength. And there's a very important component of that, and that is the mind. That it's hard to love the Lord with your mind if we don't take care of our health. And so I strongly believe in that. And that's, again, a motivation behind my desire for this subject matter. Excuse me. And here's the other, as clergy, the community of faith, we remain the first place that people retreat to help with their emotional struggles. it is highly likely that the church is where persons will go to seek their pastor for advice or counseling. If sometimes there are ministries in place, prayer ministries, small groups, and so it is statistically proven, there's some empirical evidence about the relationship and role that religious belief play in the mental well-being of individuals. And so that is, again, another important motivating factor behind this necessary conversation between or about the intersection of mental health and faith. And again, as I mentioned, I will likely be mentioning the Black church, or focusing on the Black church, not to intentionally exclude other faith communities. But again, I have to remain in my lane and speak to my context. And I believe that many of you share that context as well. So here's a historical perspective that I want to share. And I'm one that believes in the Aiken idea of Sankofa. And that is, we have to go back and get the best, go back and get what's important to us in order to move forward. The idea of Sankofa is the image is a bird, as you see, that is looking back and fetching what's behind while also moving forward. And again, I strongly believe in order for us to effectively move forward in this intersection, that we have to take under consideration the historical perspective. And there are three pieces that I would like to lift up in the historical perspective. One is an individual by the name of Imhotep. Imhotep was considered to be one of the wise persons of Egyptians that merged or created this intersection of healing and wisdom, or healing and science. He's one that was one that mastered this intersection and putting them together. He was a god of wisdom in the Egyptian mystery system, and was one who also can be considered the father of architecture. But it was not something that is new, this intersection of health and mental health and faith, that as far back as 1400 BC, we have this individual, Imhotep, who was not only a healer physically, one who mastered medicine, but also was one who combined the two with science, and did not see a tension between the two. As a matter of fact, the name itself, Imhotep, suggests the peace between the two forces, or peace within. And that's one perspective to consider as we're trying to deconstruct and debunk this whole notion that faith and science are antitheses, and that they are at odds. As it relates to the faith and the Black church, I also want for us to consider the inception of the Black church. There's an image in the center of this screen that depicts a brush arbor. The brush arbor was the space that our enslaved African ancestors developed in response to their trauma. In a real sense, the Black church was birthed out of trauma. It was a response to their traumatic experience, even while worshiping amid their slave masters. They knew that there's still a level of peace that they were seeking to experience, that what they were experiencing in the midst of their masters and during that worship service while they were being monitored, they also knew that that was not the totality of their religious experience, and certainly was not indicative of the freedom that they believed would happen to them spiritually. They believed in a God who would one day set them free. And so in addition to worshiping with the slave master, they, in an effort to create peace within, they created what's called the invisible institution, brush arbors, where you would see now we have the ring shout that is a retention of that experience, where they were able to worship around a black pot of water, realizing that water was a symbol of peace and a symbol of liberation and a direct channel to the Creator. They created the invisible institution. The Black church in which we currently worship was a direct response to trauma. It is deeply embedded in the DNA of the church. And the reason I'm bringing that to our attention from an historical standpoint is that acknowledging that piece is going to allow us to find ways to reconcile and be able to create remedy to the tension of mental health and faith in our culture and in our society. Generational trauma has found a way to masquerade as tradition in the Black church. And it's been passed down from generation to generation that has impeded our ability to fully embrace mental health. We're going to talk about a little bit more just in a second. So this is where I want to offer, in response to this historical perspective, we have an amazing history going all the way back to Egypt as it relates to this intersection. We have a recognition that one of the greatest institutions established, the Black church, in a real sense, was established out of trauma. And that trauma continues. That trauma continues by way of continuing traditions that we use to survive. But in reality, it hinders us. It hinders us from feeling comfortable being in or letting people know that we have some challenges. In one of the traumatic responses that we masquerade as tradition, it was to put on your best on Sunday morning. So within the Black church, you put on your best. There's a wealth of women on this webinar, so you can probably go back to your days as a little girl, and when you can smell Crown Royal, or is it Royal Crown? I'm probably telling on myself. Whichever one is not the alcohol, where you can smell the hot comb, and where you had to get yourself together, and where Mama made sure you were cleaned up the night before so that you could put on your Sunday best. And it did not matter what you had going on throughout the week. You put on your best face, you put on your best clothes, you put on your best image while you were at church. You wouldn't let people know what was going on around in your life. That is a retention of tradition that was birthed from the trauma of the Black church, and it perpetuates today. We put on our best. We put on the mask. We don't let anybody know that we are depressed. We won't let anybody know. We might pray about it in silence, and we might talk to the pastor, but we don't feel comfortable in the church space making others aware that I'm having a hard time right now. And so the church has not made it very easy for that to take place, because we've said things like, well, if you trust the Lord, everything would just be all right. Or if you have depression, that means you're not trusting the Lord enough. That Jesus suffered too, and because Jesus suffered, you should be able to handle it as well. So this is the phase, I want to watch my time, but this is the phase, you got to be careful with preachers who say watch their time. This is the phase where I offer an apology. I have to, on behalf of the church, as one who is a statesman of the church, one who has pastored for at least 2 decades, one who loves the church, who himself was birthed out of the church, and who considers the church as my mother in a real sense. I offer an apology, because the Black church has not done a good job at creating and offering a space that will make allowance for people to feel comfortable saying, I am not okay. We have continued a very dangerous and harmful practice. And it is now time to recognize that practice in order to move forward. Our healing takes place when our behavior changes. And one of the things I want to offer for us to go, please forgive us, please. And let us work together to not allow the apology to remain as words. So what does this look like? Or what has this resulted in? This has resulted in the stigma that is connected to mental health. And our presenter has already talked about it, so I'm not going to go too much farther into the stigma piece. Just that we must work together as a response to recognizing the generational trauma that's deeply embedded in the tradition and the DNA of the Black church, that we must work together to eliminate that trauma and eliminate the stigma. The stigma also, it continues through miseducation. One of the reasons that today, another piece is that, I guess in the 19th century, we had this resurfacing of tension between the church, faith, and mental health being at odds. And some of my clinicians may not like this piece, but Mr. Freud has a whole lot to do with that in terms of his designation, him identifying religion as being something that is delusional. And as a consequence, his influence in the field of psychology and psychiatry and designating religion as something that is delusional, it has created as a consequence this stigma behind faith and mental health, faith and psychiatry, faith and psychology. And so again, we must work together to try to remove that stigma. So how do we do this? Just again, want to offer some very practical ways that we can work together in response and recognition to the stigma and the trauma that is deeply embedded in the Black church. I want to offer at least three categories that we can individually and institutionally respond to this trauma. One, education. This is a very excellent way to help in removing the stigma and addressing the need for the intersection of mental health and faith. And that is to continue to have these webinars that will provide information about mental health and inviting persons who are practicing in the field. Again, I'm just grateful that you all scraped the bottom of the barrel and let me into this. It is a passion of mine, this work that we're doing here in Meridian. Just very grateful for you producing this for the community. Listen, the church can also offer Bible studies. There is a wealth of resources and information that today, because of the mental health issue has been heightened in recent years. There's information that's being produced and literature is being produced, curriculum being developed to help with creating space for Bible studies to help address the mental health and faith. I encourage you to individually to maybe talk to your pastor, or if you are part of the leadership team at your church or teams, invite mental health practitioners to speak, and then create a space for questions and answers, so that those questions that are deeply embedded erroneously in the mind of our community, persons in our community, will be able to have those questions addressed. I want to also offer in the area of education, and that is to provide space for our pastors to actually also be educated. One thing I recognize is that quite a few of pastors in many of the contexts I've pastored in North Alabama, North Georgia, as well as Mississippi, and there's a significant number of clergy who are bivocational. That is that they have a job, 8 to 5 throughout the day, and then they also pastor. This is a challenge because it quite often prevents them from being able to matriculate through seminary and have seminary training or have training in counseling, pastoral care and counseling. I believe that it is imperative that our pastors find some way to get involved in it. Not only I believe in the training piece, but that's another conversation, but more specifically to this conversation, our pastors should be trained in the area of pastoral care and counseling. I am very careful as to the extent to which I engage in counseling with the people who trust me. If you trust me with what's going on, then it is my responsibility to ensure that you are directed to the right person. The R word of clergy is refer. Refer. When it gets beyond our ability to share spiritually, then we must connect them with a mental health professional. And again, the education piece is a way that we can help with a healthy conversation in this intersection. I also suggest that we can help through advocacy. Every state has what it should have, and I believe they do have, this mental health day at the Capitol. And I believe that we as persons of the Black church and persons within our community, we have the ability to not only show through representation on those days, but we also have an opportunity to write and to dialogue with representatives to push them to increase funding for mental health access and mental health resources. It is amazing how many states have eliminated millions of dollars from the resources in the state to provide adequate access and care to mental health care to its constituents. And so advocacy, we can, by way of pushing and pressing our representatives, we can continue to advocate in ways by hosting mental health days, mental health fairs in our faith congregation, in our communities. We can continue to advocate individually by recognizing the mental health months, particularly July, where there's a Minority Mental Health Awareness Month, September, the Mental Health Awareness Month. I mean, these are ways that we can draw attention and advocate for, again, this intersection of mental health and faith. And then last, certainly not least, I want to offer to you this idea of partnership. Let's partner with institutions and agencies of mental health. Every city has some agency, mental health centers, mental health agencies. Find ways to connect and partner with them. The NAMI, National Alliance of Mental Illness. Most of our cities have affiliates. Most of our states are connected to the national NAMI. Find ways to connect with them, because usually throughout the year, calendar year, there are a plethora of events that will bring awareness to mental health. I want to also offer something creative, and that is to partner with school districts. So as we are partnering with agencies like NAMI and our local mental health centers, it would be incredible to partner with our school districts so that, and particularly counselors there, so that we create trauma-informed school districts that will in turn create trauma-informed schools and even trauma-informed teachers. Some of the issues that we're having in our education system is that we're expecting educators to be educators and counselors, and some of the issues that they are facing in the classroom, pre-pandemic and even within the pandemic, is not necessarily disciplinary as much as it is behavioral relating to trauma that our children are experiencing. So what wonder this would be if the church, through prayer and resources, were able to partner with school districts to create trauma-informed districts that in turn create trauma-informed schools, that in turn create trauma-informed teachers. In summary, listen, I believe the Black church can develop holistic ministries that address the healing of the whole person. You see, we don't necessarily have to have in the Black church, we don't have to have medical professionals within the church to have a mental health ministry. We can partner with mental health professionals in order to create the space, to share the resources, to help advocate and educate our community so that we can reduce the stigma and that we can truly live out what it means to be whole in Jesus. And I believe, I'll conclude with a previous statement. I'm going to advocate for every one of us to love the Lord enough to have both Jesus and a therapy. So just as much as you rush to the doctor to ensure that your body is well, I encourage you to pray and rush to find a therapist that will help you process the stuff that's going on. Jesus can actually work through a therapist. I'm a witness. Thank you so much for giving me this opportunity to share with you the intersection, or what I believe is this intersection between faith and mental health.
Amen and amen. Thank you so much, Reverend Boger. We really appreciate you. It was an amazing presentation, a much needed discussion that has to take place in order for us to move forward and progress as a people. I wanted to share something really quick with you guys, just a quick CDC. There's more than 50% of Americans that will be diagnosed with mental illness or disorder at some point in their lifetime, widely resulting from the pandemic. With numbers like these, guys, we have got to keep chipping away at the stigma surrounding this illness. We must keep the conversation going. We must push for common sense legislation that protects mental health and funding resources, as Reverend Boger did mention as well. So at this time, we would like to first thank you for just hanging in there with us. I'm so glad to see so many of you still here. We have another prize giveaway. Woo! Hooray! It's a prize giveaway. So again, you have to be present to win. We've just randomly selected another winner. And the winner for the second gift, which is a $50 Amazon gift card, is Alexandria Shaw. Alexandra, are you with us? If you could just place a quick message in the chat. Yay, Alexandria. Okay, if you could send me a direct message with your email, because it will be an e-card, we will send that to your email directly. And thank you so much. So this time we'll take questions and answers. If you can let us know if we have any questions for any of our panelists.
Yes, Sora McNeil, I do have some questions, and I'm going to start with the question for Dr. Incho. With the increased rate of suicide for males, do you have any suggestions about how women might be able, we as women might be able to support them?
Sure. I think that obviously the question is multifaceted. I think one, we've got to get a sense of, well, so for example, for my clients who are struggling with suicidal ideation and things like that, my first approach is trying to get a sense of what's the cognitions and thoughts that are driving some of this depression and then subsequently leading into suicidal ideation. And so I think first, we got to get a sense on what are the underlying things that are driving this sense of depression that then would then lead to suicidal ideation. That being true for boys as well as for men. So first step is trying to get a sense of what's driving it, what's the underlying components to it. And again, part of the problem that we're going to experience in that is that oftentimes, men will be just like, no, I'm okay, I'm all right. And it won't actually do the work that'll kind of endeavor to address it. So I think part of it is one, being supportive and trying to understand what the underlying component of it is. And then two, and I recognize that I'm biased, but to try and kind of continue to push our members with our community to seek help. Because if our depression has gotten to the place where we are suicidal and we are considering self-harm, then we're going to want to start transitioning into professional help. And so I think the other part of it is also being able to support our the men in our lives in order to be able to find and identify and utilize mental health services. And, you know, frequently I will have individuals that will contact me, women that will contact me more frequently, saying, look, I'm trying to get an appointment scheduled for my partner, for my male partner. And so that ends up being one of the ways in which some of my clients actually come to my services, because their wife or female partner has facilitated that. So I hope that rambled a little bit, but I hope I've kind of addressed the question.
Yes, I just have one follow-up question. I'm actually reading a book that suggests with men, sometimes it might be helpful not to even use the label depression, but to say you seem tired or irritable lately, you don't seem like yourself. Is there something going on? Maybe we might want to talk to your doctor about it. You're not eating as much. I'm wondering what you think about that approach.
So that's actually a great idea to actually kind of back into it. So when we think about depression, we're kind of thinking about, well, what are some, instead of the label of depression, what are some behavioral things that we're noticing? So are you not sleeping? So because when we're experiencing depression, we're going to have certain things that are going to immediately oftentimes be impacted. Sleep is going to be impacted, either sleeping too much or not sleeping enough. Our appetites can change, eating too much or not eating enough, concentration, focus, things like that. Oftentimes, one of the things I see a lot with my male clients is that we're turning to drinking more, or we're turning to other forms of addressing the emotions without actually addressing the emotions. And so if you're noticing an uptick in those type of areas, that would be a good way of identifying it as, okay, well, he's experiencing the symptoms of depression, even if we don't have to put the label of depression on it.
Okay, thank you very much, Dr. Inshow. I have one more question for Dr. DeJean. How do you help a loved one who suffers from severe depression and refuses to take their medication to assist with their depression?
Yes, that is such a great and common question. I think, we do have to leave space for them not being ready. And first, just being okay with the fact that you may have to have multiple conversations with that person. But I think the first thing is to start and talk about the impact that you are seeing from that. So if the depression is impacting you in some way, you could say, hey, I don't feel connected. I feel like we're not as close, or I'm feeling like I'm noticing a change in you, and it's hurtful to see you struggling so much. Really just coming from that empathic stance, referring them to seminars like this or webinars. If there's someone that in the family that has struggled with depression, that can kind of be an advocate and maybe kind of lead them along the way, getting them in touch with people that you trust to talk to them. Those would be the measures I take, but it is sometimes hard to really convince people. Also getting to the why that they don't want to get in touch with treatment. Why is it that you don't want to? Understanding that why might help you to counteract some of the barriers that they may be telling you about.
Thank you very much. The next question that I have is for Dr. Webb, and it is, would you consider glutting and binge eating to be the same thing?
Well, to be diagnosed with binge eating, you have to engage in rapid and quite a bit of food in a short amount of time. And usually that's about a 2-hour time period, and really feeling out of control. And it has to be at a certain time, meaning how the frequency of the binge eating episodes. So there's quite a few things that go into the diagnosis of binge eating.
Thank you very much, Sora Webb. We are getting at the end of our time, and therefore we won't be able to ask any more questions, but I am going to be cataloging all of the questions in the chat, and we will put together a frequently asked questions to display along with this presentation. Thank you very much for your participation and your wonderful questions.
Thank you, Dr. Means. So again, guys, thank you so much. We will be also emailing you the frequently asked question and answer to your email. For those of you who registered and provided your email addresses, you will receive the questions and answers there. We will also be sending you guys a link to the survey. If you weren't able to complete it during this time, we'll be sending that to you via email. And we would love if you could just take a moment and complete that survey, just because it's important to us to make sure that we're curating programs, that are helpful to our communities. So please just take a few minutes to do that. And thank you so much for coming today and joining us for this mental health webinar. We definitely plan to keep the conversation going. Hopefully sometime in the near future, we will have additional seminars with different topics and speakers, just to really keep the conversation going, because not talking about mental health is what's the hardest, I think, of dealing with the illness. So you can count on us to keep that going. Again, thank you for coming. If you have any questions, please put them in the chat. You have a couple more minutes now to just throw them in there really quick, directing them to Q&A, because we will have those answered and sent to you via email. But thank you, all the presenters. You guys were all amazing. I really hope that you guys were able to take away some great information, some wonderful resources that were provided to you guys for follow-ups after this presentation. But again, thank you, amazing presenters. Thank you so much to the Marietta Roswell Alumni Chapter for providing this seminar. Thank you to the Physical and Mental Health Committee that worked so hard with me in putting this together. But again, we appreciate you. We hope those small tokens of appreciation you will enjoy. And for the rest of you guys, again, just take a minute to let us know what you thought about the program. Thank you so much, and have an amazing weekend. Bye.